do you think North Star trial also suit for ALK?
ALK, yeah,
patient?
yeah. I think that's a great question, and I think in some ways studies like the North Star study make me think that the boundary between what we think is early stage disease and late stage disease is really very gray. And this paradigm which which we're starting to use in advanced disease, you treat with the TKI and then any residual disease, potentially you can treat with surgery or stereotactic radiotherapy. I think it makes a lot of sense to me because we know from from biology that there are cells called persister cells which the TKI can't get rid of. But the surgeon can, with his scalpel, get rid of those cells. So I think that makes a lot of sense to me. And in the same way that we think early stage disease, we know with ALK from the ALINA study, more than half of patients had N2 disease, and we know that there's a high propensity for brain metastases. So even what we think is early stage is kind of, early with a bit of late. So I think the boundaries are getting broad. And to me, that means even for, well, we know resectable, but definitely also potentially resectable disease, that there is a role for a TKI. And I think in patients with advanced disease, there is also a role for surgery. Those patients that we might think are not suitable for an operation, we treat with a TKI alone, or another good question is where does chemotherapy fit in there? But we'll say for the moment with TKI, those patients, I think, with residual disease, in my view, are likely to benefit from surgery. The other thing the other real opportunity is to study that surgery will give us a sample that we can use to really understand the biology of these persister cells. And if we can effectively deal with these persister cells, I think that is the way we get to cure. Yeah, I think it's a really interesting time for oncogene-driven cancers.
So I want to ask Professor Solomon, do you think it's reasonable to switch before a PFS? And
Yeah.
why?
Yeah, look, I think it's a really good question, and this is something obviously since the Crown data have come out, we've sort of had to talk to patients about. I think there is a strong rationale. With alectinib, we see the PFS is 35 months. With lorlatinib, it's more than 60 months. Who knows how long it will be. But what I've found is that patients, particularly patients who've been on alectinib for 2, 3, 4 years, they're very reluctant to change because they're tolerating the drug well. They may be in the good part of the curve. And I've had very few patients that, even with sort of discussion of the data, have wanted to switch. I do talk about that. But what I do in practice is I don't wait for RECIST progression. So, RECIST lesion has to increase by more than 20%. Even if on the scan there is tiny progression, even 1 millimeter of progression, to me that is time to change. Now you may say that's too late, but I do that. In the past, if we had some progression, we would use stereotactic radiotherapy and continue the second generation inhibitor. I don't think there's a good reason to do that now. I think we should change. But for us, it's maybe a little bit different because we've been using first-line lorlatinib for a long time. So it doesn't sort of come up that often about the switch question. But I think the rationale to switch is strong, but my patients have not been so keen, is my experience.
So I have questions for Solomon, actually, and I think this is a very good opportunity. And I just mentioned for if there is, for example, T4N2 patient as a 3B as a potential, resectable patient. Will you give them ALK TKI first and then surgery?
Yeah, look, I think the issue that there's an access issue, but if we take the access out and if we sort of think about biology, I think it does make sense to do that. It doesn't make sense to me. So we know we can't give neoadjuvant chemoimmunotherapy. We know that the immunotherapy doesn't work. We know that ALK and EGFR patients are excluded from that trial. So we know that chemoimmuno is not an appropriate neoadjuvant strategy. To me, giving chemotherapy before the surgery does not make a lot of sense when we know that giving a ALK TKI is going to have a much higher response rate, much higher chance of downstaging the tumor than chemotherapy. So I think it is a very reasonable strategy to do that. I do think, however, that the patient will also require adjuvant treatment with the TKI after the surgery. We have seen some situations. I'd be very interested in your experience. What we have seen is that we have seen some patients that have had very good responses, even cleared their nodal disease, but they still have a little bit of residual tumor in the primary. We've also seen, at least my surgeons tell me, I'm a medical oncologist, not a surgeon, but my naive way of thinking was that the TKI would not affect the operative field. But my surgeons tell me that they have seen that the operations can be difficult. They can see some scarring, some fibrosis even after the TKI, which to me was unexpected. But I'd be very interested in your experience, Professor Yan, with surgery after TKIs, both EGFR and ALK. Do you find it makes the operation more difficult or easier?
Yeah, more difficult.
Yeah.
Maybe for EGFR patient, it's difficult. And for ALK patient, it's more difficult.
Mm.
It's difficult. The
That's very interesting. Yeah.
But we can, perform R0 surgery. So we designed several small trials, maybe 20, 30. It's a small trials. Thank you very much. And the last question I just mentioned is a drug holiday. So for Crohn, after 5 years, maybe it's a already kill all the cancer cells. Do you think it's reasonable to give the drug holiday?
Yeah, so I used to, so I go back to the example of the hematological cancer, chronic myeloid leukemia, CML, which is another fusion-driven cancer, which the BCR-ABL oncogene and can be treated very effectively with tyrosine kinase inhibitors. In that situation, they have very sensitive MRD assays. And in patients who've had complete molecular responses, those patients can stop drug, and about a third of them can even stay off drug. With lung cancer and with ALK, we don't have MRD assays are not that good, but they are getting better. And Professor Yilong Wu's group have demonstrated that there is a group of patients who've had long-term control of their disease, who have no detectable ctDNA, that you can safely give a drug holiday. So I think this is an interesting concept. But to me, almost another more interesting question is, in that lorlatinib Crown study, we're seeing patients at 5 years, 7 years that haven't progressed and very flat line. is it possible that some of those patients are actually cured of their disease? We don't know that, but I would love to learn that in the future.
Yeah, thank you very much. And I think the escalated methods, maybe we should study it, have more trials to prove that. But still, I think it will be very good to patients. For patients, they take drug for the all life.
Yeah.
Maybe it's not miserable, I think.
Yeah, less
But now,
financial toxicity too, right? So
yeah, of course.
yeah.
Thank you very much. I think we just have a very good time this afternoon, and I think you and Professor Liang gave us a very good talk. And during the discussion, we talk a lot and very deep. I think there are many new ideas from Professor Solomon.